Welcome back. We are on Chapter 9, Airway Management. We will be going over the following topics in this chapter: airway physiology, airway pathophysiology, opening the airway, obstructed airway, airway adjuncts, suctioning, keeping the airway open, definitive care, and special considerations. In this section, we're going to talk about airway physiology. Airway physiology. So, the movement of air into and out of the lungs requires an intact open airway or a patent airway. This means that the airflow is an unobstructed and capable of moving air freely in its path. So the upper airway is where the air enters the body through the mouth and the nose, where the nose is specifically designed to accept the air through the series of different turns and curves and so forth, and that is when the air is warmed and humidified as it proceeds through those nasal passages. But then the mouth is primarily designed for the entrance to the digestive system, but it can also be an entryway for the air. So typically the mouth is going to be used in more of an emergency situation. So when they're mouth breathing, typically it is more because of an emergency situation like, asthma or trauma of some sort. Then you have the posterior and inferior to the mouth and the nasal passages where air enters the throat or the pharynx. So remember, the pharynx is divided into three regions: the oral pharynx, and that's where the area of the mouth or the oral cavity joins the pharynx. Then you have the nasal pharynx, where the nasal passage empties into the pharynx. And then finally you have the laryngopharynx, which is the structure surrounding the entrance to that trachea. Then remember, you got the vocal cords, which are considered the glottic opening and define the boundaries between the upper and the lower airway. The laryngopharynx, which is also known as the hypopharynx, is designed to provide structure to and protect the opening to that trachea. It is also the point of division between the upper airway and the lower airway. So the entry point into the larynx, or called the glottic opening, is protected by a large leaf-like structure called the epiglottitis. The epiglottis. Epiglottitis is the infection they get. So this is the protective flap that sits above the glottic opening, which is designed to seal off the trachea during the swallowing or in response to the gag reflex. So the glottic opening is also protected by the vocal cords. So these curtain-like fibers, or that's what they call them, as curtain-like fibers, that line either side of the tracheal opening, not only can close and shut for protection, but it also vibrates with the passage of air to create the voice. Here's a diagram of the upper airway, which again can be found in your book. Next, we'll talk about the lower airway. So that begins below the glottic opening and is composed of the trachea, the bronchial passages, and the alveoli. So from the glottic opening, the air enters that trachea, and then the trachea, which is that tube that's protected by the 16 rings of cartilage. So these rings then provide structure and prevent the trachea from actually collapsing. And then the top ring is the cricoid ring, which extends fully that 360 degrees around. So in other rings, the cartilage extends only about 3/4 of the way around and is connected posteriorly by smooth muscle. So the trachea branches at the carina and forms into the two main stem bronchi. So these large branches then are further subdivided to form smaller and smaller airway passages called the bronchioles. At that point, then all the air passages are supported by cartilage and are lined with the smooth muscle. So the smooth muscle then allows for those bronchioles to change their internal diameter in response to that specific stimulation. The bronchioles then end at the alveoli, and those alveoli are those tiny sacs that occur in like a grape, like bunches at the end of that airway. So with that, then these alveoli are surrounded by the pulmonary capillaries, and it enters through the thin membranes that the oxygen and carbon dioxide are diffused, and that's that gas exchange that will be discussed, later on in the chapters. But it's important to remember that the bronchioles divide and travel in every direction. So as a result, those tiny bronchioles and the millions of little alveoli in which they are connected cover most of the anatomic regions of the chest from the collarbone to the diaphragm. So it's a very large area. Here is the diagram of the lower airway, the bronchial tree. And here is the lower airway with the alveolar sacs, which are those clusters of individual alveoli. Next, we are going to move on to the pediatric airway physiology. So the airway structures of infants and children are shorter, narrower, and less rigid than in the adults. So a few things you need to remember and know is that the mouth and nose are smaller and more easily obstructed. The tongue is proportionately larger. Newborns and infants are typically nose breathers. The trachea is softer, more flexible, and narrower and more easily obstructed by swelling and foreign objects. Then the chest wall is typically softer and breathing is more dependent upon the diaphragm. Here you will see the comparison of a child and adult respiratory passages. In this section, we're going to talk about airway pathophysiology. All right, so for air to make the journey through the nose and the mouth to the lungs, the pathway must be relatively unobstructed. So there's a variety of obstructions that can occur with airflow. So foreign bodies include in food and small toys, liquids including blood and vomit, and then loss of muscle tone as with that altered mental status. So obstructions can be acute or it can be chronic. So remember, acute means it happens right now. There was nothing that was going on before, whereas chronic is it's been something that's been happening and leading up to. So it's been a continual thing. And then the airway must be initially evaluated and monitored for patency over time. So when you do have an airway problem, or maybe you don't, you do have to recheck their airway often to make sure that they still have a patent and open airway. Next, you have severe allergic reaction, also known as anaphylaxis, which causes rapid airway tissue swelling. You could have burns or blunt force trauma, and then certain infections can cause swelling of the tissues in and around that glottic opening. Smooth muscle constriction of the lower airway changes the airway diameter and then creates resistance. So next we're going to talk about a partially obstructed airway, which can be identified by the sounds of limited air movement, but understanding these sounds can actually help you better understand the pathophysiology of that obstruction. So the first one is going to be stridor. So stridor is typically caused by a severely restricted air movement in the upper airway. As air is forced by pressure through that partial obstruction, a high pitch, sometimes almost a whistle, can be heard. So typically, stridor indicates a severely narrowed passage of air and suggests a near obstruction. So in stridor, the obstruction can be a foreign body, such as a toy, or it can be caused by swelling of the upper airway tissues, typically, most of the time, an infection. The next one is going to be hoarseness. So your voice changes, such as stridor, and often reflects the narrowing of that upper airway passage. So the voice changes are often useful in assessing an ongoing airway issue. So for example, in a person whose airway is swelling after a burn, you may note a normal voice to begin with, but a raspy voice as the swelling builds up and around the vocal cord. So the development of the hoarseness is often an ominous sign. Just like somebody like me as an instructor who talks a lot or does, 3 or 4 presentations in a row, that my first presentation might be okay, but by the time I get to my 3rd or 4th presentation, you're hearing the hoarseness, the crackling, and so forth in my voice. And so what happens with that is your voice is, if you're not used to talking all the time, that's a different movement for your tissues. So it can actually begin to swell. The next one is snoring. So snoring is the sound of soft tissue of the upper airway creating impending or a partial obstruction, to the flow of air. So many persons normally snore while asleep, but snoring in the case of an injury or illness can often indicate a decrease in mental status, such as the airway muscle tone is diminished. So it's also an indication that an airway needs assistance to stay open. So if you go out to a trauma call or a head injury of some sort and the patient's in, say, the ditch snoring, that doesn't mean they're taking a nap, they just fell asleep and they're snoring. That means there's something that they've had a traumatic injury of some sort that has caused them to begin to snore, going back to that injury or illness, which can happen during trauma. Next is gurgling. So gurgling is the sound of fluid obstruction in the airway, and air is forced through the liquid, and then that's where that gurgling sound is made. So the common liquid obstruction includes vomit or blood or any other airway secretions. So gurgling is a sign that immediate suctioning is needed. And the quick and easiest thing is if you hear somebody breathing, that is not a normal breathing. You should not be able to hear people breathe. So a question you need to ask yourself during the patient assessment is the airway open? There's two questions that must be answered when assessing the airway. Is the airway open, and will the airway stay open? So the ability to speak is an immediate indicator that the patient is capable of moving air. Stridor may be present on inhalation, exhalation, or both, and is an ominous sign. Breathing sounds from the nose and mouth should be free of sounds associated with obstructions, considering gurgling, gasping, crowning, wheezing, and snoring an obstruction. So some patients use body position to keep their airway open. And then you want to assess the airway in the primary assessment and stop and fix the problem immediately. So another question to ask is, will the airway stay open? So airway assessment is not just a moment in time, but a constant consideration. This is especially true in critical patients. You may need to consider how to keep an airway open immediately after establishing it. When the airway is partially obstructed, you must consider how long it will be completely obstructed. The ability to maintain an airway can change over time. So mental status affects the ability to maintain an airway, and there is no guarantee that an airway will remain open. Signs of an inadequate airway include no signs of breathing or air movement at all. They may have evidence of a foreign body in the airway, or no air felt or heard at the nose or the mouth. The inability to speak or difficulty speaking. Unusual hoarse or raspy quality to their voice. An absent, minimal, or even uneven chest movement. Breathing movement limited to the abdomen. Diminished or absent breath sounds. Abnormal noises such as wheezing, crowing, stridor, snoring, gurgling, or gasping during breathing. In children, retractions above the clavicles and between the ribs. And in children and infants, nasal flaring. In this section, we're going to talk about opening the airway. Opening the airway. Airway problems must be dealt with immediately. If you don't have an airway, you don't have a patient. Open and maintain the airway in a patient who cannot do so for him or herself. In a patient with diminished mental status, airway procedures are best done with the patient supine. If you suspect spinal trauma, you want to protect the head and neck. The airway has priority over spine protection. And you want to provide manual stabilization if time does not allow for spinal precautions. In unconscious patients, you want to watch for indications of head, neck, and spinal trauma. The mechanism of injury causes such injuries. The injury is at or above the level of the shoulders. Family or bystanders indicate such injuries occurred. Some patients have open but threatened airways. A conscious patient should be helped into a comfortable position. Unconscious patients should be placed in a head elevated sniffing position. The slight elevation and anterior positioning of the head aligns the airway structures for improved patency. The head is moved into an anterior fashion similar to the posture used to sniff flowers. In supine patients, this may be achieved with a 1.5 to 2 inches of padding behind the head. Anatomy and head size can create unique positioning needs. In pediatric patients, padding may be needed behind the shoulders. The optimal position is achieved when the patient's ear is at the same level as the suprasternal notch. The position may be contraindicated when there is a risk of spinal injury. Next, we're going to talk about providing an airway with manual maneuvers. So patients without an intact airway require manual airway opening and ongoing interventions to support patency. Airway problems are often caused by diminished control of muscles in the airway. Basic procedures keep the tongue in position and prevent the epiglottis from covering the glottic opening. The head tilt chin lift maneuver and the jaw thrust maneuver are commonly used, remembering that the jaw thrust maneuver is used on all trauma patients. And if it is a trauma patient, it should be the jaw thrust maneuver. The head tilt chin lift maneuver aligns the airway structures to provide for free passage of air. Number 1, you want to place one hand on the forehead and the fingertips of the other hand at the corner of the lower jaw. Next, you're going to tilt the head by applying pressure to the forehead and lift the chin and support the lower jaw. Then you're going to move the jaw forward and do not allow the mouth to close. Here you will see the head tilt chin lift maneuver. This is a side view, and the right image shows that the EMT's fingertips are under the bony area at the center of the patient's lower jaw. The jaw thrust maneuver is used to open the airway of an unconscious patient with a spinal injury. First, you want to keep the head, neck, and spine aligned, moving the patient as a unit into the supine position. Kneel at the top of the head, and then place one hand on each side of the lower jaw at the angle of the jaw below the ears. Then you're going to push the angles of the lower jaw forward with the index fingers. You're going to retract the lower lip with your thumb to keep the mouth open, and do not tilt the head. Here is the jaw thrust maneuver, and this is also a side view. So you'll see it shows that the EMT's fingers are positioned at the angle of the jaw, just below the ear. And this maneuver is made for trauma patients. So if you have anybody with a trauma, you're going to be doing the jaw thrust maneuver. In this section, we're going to talk about obstructed airways. If an open airway remains obstructed, consider the possibilities of a foreign body obstruction. If attempts to ventilate and reopen the airway fail, then you want to immediately begin foreign body airway procedures. Choking is classified as a severe or non-severe. In severe choking, the trachea is fully blocked and no air is moving. In a non-severe choking, the trachea is partially blocked and some air is exchanged. Conscious, severely choking adults are treated with abdominal thrusts. You want to stand or kneel behind the patient. Place a fist over the navel and grasp the fist with the other hand. Press the fist into the abdomen with a quick, forceful upward thrust. And repeat the thrust until the obstruction clears or the patient becomes unconscious. Conscious, severely choking infants are treated with back slaps and chest thrusts. You want to lay the infant along the forearm in a prone position with the head lower than the body. You're going to support the head with your hand. Deliver 5 forceful back slaps with the other hand. Cradle the infant with the forearms and turn him over with the head lower than the body. You're going to deliver 5 rapid chest thrusts at 1 per second. Alternate slaps and thrusts until the obstruction clears or the patient becomes unresponsive. If you cannot wrap both arms around the adult patient to deliver thrusts, position the hands over the sternum. If the choking patient is unconscious or becomes unconscious during the airway maneuvers, begin CPR. In this section, we're going to talk about airway adjuncts. Airway adjuncts. Manual maneuvers open the airway, but an obstruction may resume when a maneuver is released. Airway adjuncts aid in maintaining an open airway. There are 2 common types of airway adjuncts: the oropharyngeal airway, also known as an OPA, or a nasopharyngeal airway, known as an NPA. The main function of these devices is to keep the tongue from blocking the airway when the muscle tone is diminished. Here's some rules for using airway adjuncts. You're only going to use an OPA on patients not exhibiting a gag reflex. Gag reflex may reappear as the patient regains consciousness. If an OPA is not tolerated, an NPA may be. Open the patient's airway manually before using an adjunct device. When inserting the airway, you want to take care not to push the patient's tongue into the pharynx, and have suction ready prior to inserting any airway. Do not continue inserting airway if the patient begins to gag. You want to maintain head position after the adjunct insertion and monitor the airway. Continue to be ready to provide suction if the fluid obstructs the airway. If the patient regains consciousness or develops a gag reflex, remove the airway immediately. Use infection control practices while maintaining the airway. Oropharyngeal airways. An OPA is a curved plastic device inserted in the mouth to keep the airway open. It has a flange that rests against the patient's lips. It moves the tongue forward as it curves back to the pharynx. OPAs come in standard sizes. They range in size from infant to adult. A complete set should always be carried. An airway is not effective unless it is the correct size. Here are some examples or different sizes of the airway adjuncts for the oropharyngeal airways. To determine size, you want to measure the device from the corner of the mouth to the tip of the earlobe on the same side. Alternatively, you want to measure from the center of the mouth to the angle of the lower jawbone. Do not use a device unless you have measured and verified the sizes. If the airway used is too big, air will be directed into the stomach instead of into the lungs. With the oropharyngeal airway, you're going to measure from the corner of the patient's mouth to the tip of the earlobe. Or you can alternatively measure from the center of the mouth to the edge or the angle of the lower jawbone. Steps for inserting an OPA. First, you want to place the patient on his or her back and use appropriate manual method to open the airway. Next, you're going to open the mouth with a crossed finger technique. Position the airway device with the tip pointing toward the roof of the mouth. Insert the device along the roof of the mouth. You're going to use a crossed finger technique to open the patient's mouth. Then you're going to insert the airway with the tip pointing to the roof of the patient's mouth. You're going to then gently rotate 180 degrees so the tip is pointing down into the patient's pharynx. Position the patient and check that the flange of the airway is against the patient's lips. Monitor the patient closely. Nasopharyngeal airways. An MPA is used when there is an intact gag reflex, teeth are clenched, or there are oral injuries. It may be contraindicated with basilar skull fractures, epistaxis, which is nosebleed, or nasal trauma. Soft, flexible airways should be used in the field rather than rigid and clear plastic airways. Steps for inserting an NPA. You want to measure for the correct size from the nostril to the tip of the earlobe or the angle of the jaw. You want to lubricate the outside of the tube with a water-based lubricant before insertion. Push the tip of the nose upward and insert the airway. Keep the head in a neutral position and point the bevel toward the base of the nostril or toward the septum. Here you will see another form of airway adjuncts, the nasopharyngeal airway. So you're going to measure from the nasopharyngeal airway from the patient's nostril to the tip of the earlobe or to the angle of the jaw. You're going to apply a water-based lubricant before inserting. And you're going to gently push the tip of the nose upward and insert the airway with the beveled side toward the base of the nostril or toward the septum, which is the wall that separates the nostrils. So you're going to insert the airway, advancing it until the flange rests against the nostril. Insert into the nostril. Advance along the floor of the nasal pharynx, and the flange should rest firmly against the nostril. Next is the supraglottic airway. Supraglottic airways isolate the glottic opening by occupying space in the larynx and the hypopharynx. Airways are indicated when other basic measures have failed. May also be used if the airway must be maintained over a long period of time. And specific insertion steps vary by the airway manufacturer. General steps for inserting a supraglottic airway include preparing the patient. You want to attempt simple procedures first. If these fail, position the patient's head and pre-oxygenate the patient. Next, you're going to prepare the team. Discuss roles and responsibilities. Assign suction, assessment, and equipment duties. General steps for inserting a supraglottic airway is to 1. Prepare the device. Size the device per manufacturer's instructions. Attach and check any required inflation devices, and prepare for suctioning. In this section, we're going to talk about suctioning. Foreign materials that remain in the airway may be forced into the trachea and lungs, causing complications. Gravity can be used to clear fluids from the mouth by turning the patient to one side and allowing fluids to drain. This is fast compared to technical alternatives. It can be done while devices are being prepared. It cannot be done with spinal injuries or whenever there is a single responder. When using gravity, always be sure to turn the patient away from your body. Suctioning devices. Suctioning uses a vacuum device to remove foreign material from the airway. A patient with fluid or secretions present or a gurgling sound should be suctioned immediately. Each suction unit includes a suctioning source, a collection container, tubing, suction catheters, and tips. Vehicle-mounted or onboard suction units. You want to create a suctioning vacuum using the engine's manifold or the electrical power source. You must furnish an air intake of at least 30 liters per minute at the end of the collection tube. And you must generate a vacuum when the collecting tube is clamped. Portable suction units. It may be oxygen or air powered, electrically powered, or manual. You must provide an amount of suction identical to that of an onboard unit. Here's a mounted suction device that is installed in the ambulance's patient compartment. This does not come out of the truck. So what goes into the operation of a suction unit? It requires tubing, suction tips, suction catheters, collection containers, and a container of clean or sterile water. The most popular suction tip is the rigid pharyngeal tip, also called a Yonkers or a tonsil tip. It allows the mouth and the pharyngeal suction with an excellent device control. It has a larger bore than more flexible catheters, and it is most successful with an unresponsive patient. Suction catheters are flexible plastic tubes. It comes in sizes identified by a number, which is called a French. It is designed for use in situations when a rigid tip cannot be used. The collection container should be a non-breakable and easily removable. The water container is used to clear partially blocked tubing. Pediatric suctioning. Infants are very sensitive to vagal stimulation from catheter contact with the hypopharynx. They will respond with a slowing of the heart rate. Minimize the necessary suctioning time and take care to avoid the hypopharyngeal contact. Bulb syringe suctioning is common in infants and small children. It is very effective in clearing smaller airways. It is used in childbirth and when the infants experience respiratory distress. Suctioning techniques. You always want to use the appropriate infection control practices while suctioning. When possible, limit suctioning to no longer than 10 seconds at a time. Place the tip or the catheter where you want to begin suctioning and suction on the way out. Suction is best delivered with the patient on his or her side. Suction devices may activate the gag reflex or stimulate vomiting. You're going to position yourself at the patient's head and turn the patient's head or entire body to the side. In this section, we're going to talk about keeping an airway open, definitive care. Keeping an airway open, definitive care. Keeping the airway open may exceed capabilities of a basic EMT. You want to rapidly evaluate and treat airway problems. Quickly recognize when more definitive care is needed. It may be advanced life support intercept, or it may be to the closest hospital. There is also an option for air medical if needed. In this section, we're going to talk about special considerations. Special considerations. First is facial injuries. Bleeding may require frequent suctioning. An airway adjunct or endotracheal tube may be needed. The next one is obstructions. Suction units are not adequate for removing solid objects. You want to use the abdominal thrust, chest thrust, or finger sweeps if required. Dental appliances. Dentures should be left in place during the airway procedures if they're not loose. Partial dentures may become dislodged during an emergency. Be prepared to remove a device if it endangers the airway. Let's go over the chapter review. The airway is the passageway by which air enters the body during respiration or breathing. A patient cannot survive without an open airway. Airway adjuncts are the oropharyngeal airway, or also known as the OPA, and the nasopharyngeal airway, which is the MPA, which can help keep the airway open. It may be necessary to suction the airway or to use manual techniques to remove the fluids and solids from the airway before, during, or after artificial ventilation. Remember, you always want to use proper personal protective equipment when managing an airway. Airway assessment must be an ongoing process. Airway status can change over time. Airway management should start simply and become more complicated only if necessary. Questions to consider. Number 1, name the main structures of the airway. Next, explain why care for the airway is first priority of an emergency care. And describe the signs of an inadequate airway. Explain when the head tilt chin lift maneuver should be used and when the jaw thrust maneuver should be used to open the airway, and why. Explain how the airway adjuncts and suctioning help in airway management. Critical thinking. On arrival at the emergency scene, you find an adult female patient with gurgling sounds in the throat and inadequate breathing slowing to almost nothing. How do you proceed to protect the airway? Remember that gurgling indicates suctioning. Other necessary treatments include positioning, insertion of the airway adjunct, and positive pressure ventilations. When evaluating a small child, you hear stridor. What does this sound tell you? What are your immediate concerns regarding this sound? Just remember that stridor indicates a partially obstructed airway. Immediate concerns include the fact that this airway is threatened and could be completely obstructed. When assessing an unconscious patient, you note snoring respirations. Should you be concerned with this? And if so, what steps can you take to correct the situation? Remember that snoring indicates at least an airway impedance, and at worst, poor muscle control of the airway. So typically, better positioning and/or insertion of an airway adjunct will relieve this problem.